In this lecture, you are going to learn how to choose an appropriate antimicrobial agent taking into several factors into consideration. So if a patient gets admitted to the hospital with clinical manifestations of infection, an antibiotic is initiated. So the four vital steps of antibiotic prescribing is, so the first one is diagnosis of the clinical entity or the infectious disease based on the signs and symptoms, and if the infection is serious, the patient sample is sent for culture sensitivity testing. Now the culture sensitivity reports takes 24 to 48 hours to arrive. Meanwhile, an antibiotic is initiated. Usually a broad spectrum antibiotic is selected that covers the likely pathogens. And this type of prescribing is known as empirical prescribing. So empirical prescribing includes prescribing a broad spectrum antibiotic that covers all the likely pathogens. Now, as the culture reports are available, based on the susceptibility pattern of the microorganism, the antibiotic can be changed from a broad spectrum to a narrow spectrum that selectively targets a particular microorganism, and this type of therapy is known as definitive therapy or targeted therapy, where a narrow spectrum antibiotic is chosen that targets a particular microorganism. Now, during the course of antibiotic therapy, response to therapy is monitored. So, the antibiotic prescriptions are reviewed periodically and the antibiotic may be changed from broad spectrum to narrow spectrum. And during the course of antibiotic therapy, response to treatment is monitored. So you look for the clinical status of the patient, the improvement in the signs and symptoms, improvement in microbiological data, and also improvement in the radiological investigations. So the vital steps of antibiotic prescribing is diagnosis of infection, empirical prescribing, definitive therapy, and monitoring of response to treatment. So now that you have learned about the vital steps of antibiotic prescribing, let's now discuss how to choose an appropriate antimicrobial agent taking several factors into consideration. So the factors that are considered are pathogen related factors, patient related factors, and drug related factors. Now the likely pathogen or the type of microorganism is identified based on the site of infection. For example, if the site of infection is skin or soft tissue, then the organism is Streptococcus pyogenes and Staph aureus. If the site of infection is respiratory tract, then the organism is Streptococcus pneumoniae or H. influenzae. The site of infection is GI tract, then the organism is Salmonella, Shigella, E. coli. If the site of infection is genitourinary tract, then the organisms are E. coli, Proteus, Klebsiella. If it is a bloodstream infection, then gram-negative bacilli and Staph aureus may be the causative organism. So the site of infection gives a hint. You can guess the type of microorganism, the likely microorganism which is related to the site of infection. Next is that you can assess the local antibiogram or hospital antibiogram. So what is a hospital antibiogram? A hospital antibiogram is a summary report which shows the antimicrobial susceptibility pattern of pathogens that are isolated from a hospital facility from the patients and for a specified period of time. So the hospital antibiogram helps to track the resistance pattern of the microorganism and acts as a guide, it acts as a tool for empirical prescribing. So next is the patient-related factors. So the first factor is age. Age affects the pharmacokinetics of many of the antimicrobial agents and this causes adverse effects. So the extremes of age, particularly the neonates and the elderly, are commonly affected. For example, chloramphenicol causes grey baby syndrome in the newborn. So the baby stops feeding, there is vomiting, there is distension of the abdomen, hypotonia and hypothermia. The respiration becomes irregular, there is cardiovascular collapse, and this can lead to a death of the baby. The second example is that of sulfonamides. Now, sulfonamides can displace bilirubin from the plasma protein binding sites, increasing the concentration of unconjugated bilirubin. So, unconjugated bilirubin readily crosses the blood-brain barrier and gets deposited in the basal ganglia of subthalamic nucleus, and this can cause kernicterus in newborn. The third example is tetracycline. Now tetracycline gets deposited in developing bones and teeth, and this can cause staining in the teeth and deformities. Therefore, these drugs or antibiotics are avoided in children, in neonates. In elderly patients, as the renal function declines, aminoglycosides should be prescribed cautiously because aminoglycosides are primarily excreted through the kidney. It is also known to cause ototoxicity. It can cause eighth nerve toxicity in elderly, and therefore aminoglycoside antibiotics should be cautiously used in elderly patients. Next is end organ dysfunction, which includes liver disease and renal disease. In liver disease, the antibiotics that are prescribed in tuberculosis, for example, isoniazid, rifampicin, pyrazinamide, are some of the commonly first-line antibiotics that are used for the treatment of tuberculosis. Now, amongst these drugs, pyrazinamide is most hepatotoxic. Therefore, pyrazinamide is avoided in a patient with liver disease, while isoniazid and rifampicin can be used with dose modification. Erythromycin is primarily excreted in bile, therefore it is avoided in liver disease. So the antibiotics that are safe in liver disease are third generation cephalosporins such as ceftriaxone and cefotaxime. So ceftriaxone, cefotaxime are third generation cephalosporins that are safe in liver disease. Next we move on to kidney disease. Now, nitrofurantoin is an antibiotic that is commonly used for the treatment of urinary tract infection. The active drug is excreted in urine and it exerts its antibacterial action in urine. Therefore, in kidney disease, nitrofurantoin is not effective. It should be avoided in a patient with kidney disease. Secondly, antibiotics such as aminoglycosides, amphotericin B and vancomycin are highly nephrotoxic drugs and therefore need dose reduction even in mild renal failure. So the next is local factors. Now in local factors, presence of abscess formation or pus decreases or influences the efficacy of many of the antimicrobial agents. This is because abscess formation or pus formation creates an environment that is low oxygen, low pH and high protein environment, and antibiotics such as aminoglycosides are highly active at alkaline pH. They require alkaline pH to act. So in acidic pH, the efficacy of antimicrobial agents such as aminoglycosides is decreased. So pus formation decreases the efficacy of many of the antimicrobial agents. So drainage of abscess should be considered because draining the abscess decreases the population of the bacteria, increases exposure to oxygen, thereby suppressing the anaerobes, and also increases the diffusion of the antibiotic to the site of infection and enhances the efficacy of the antibiotic. So the abscess formation should be drained to increase the efficacy of the antimicrobial agents. The second is presence of foreign bodies such as drains, tubes, catheters increases the risk for infection. So this is a figure which shows an inserted central venous catheter. So the bacteria from the skin gets adhered to the medical device and generates a film of biofilm. So biofilm formation or the layer of biofilm protects the bacteria, so the bacteria slowly grows. So this makes the bacteria difficult to reach and less vulnerable to the antibiotics. So the antibiotics cannot reach the bacteria because of the layer of biofilm. Now the layer of biofilm further matures and gets detached from the device into the bloodstream, causing bloodstream infections. So catheter related bloodstream infections are very common. Therefore, good infection control practices should be followed such as hand hygiene, sterile techniques, skin antisepsis, selection of an optimal site. So all this needs to be considered during insertion of a catheter, during insertion of a drain. Next is penetration barriers. Bacteria at certain times remains hidden under certain barriers. For example, the vegetations that are present in the heart valves as in infective endocarditis, or blood-brain barrier which limits the entry of the antibiotic to the CSF, to the brain, or the eyeball that acts as a penetration barrier. The antibiotic has to be lipophilic to penetrate the cornea and enter into the ocular tissues or enter into the ocular fluid. So penetration barriers play a very important role in influencing the efficacy of the antibiotics and needs to be considered when using antibiotics. The next factor is earlier drug exposure or history of allergy is obtained. This helps a clinician to choose or select an appropriate antimicrobial agent. For example, in syphilis, penicillin is the drug of choice, but if the patient is allergic to penicillin, tetracycline may be used instead of penicillin. So the next factor is host defense, which plays a very important role in selecting an antimicrobial agent. For example, if the host defense is normal, a bacteriostatic agent may be selected. So bacteriostatic agent suppresses the growth and multiplication of the bacteria. But if the host defense is impaired, so a more intensive therapy is needed with a bactericidal agent which induces killing of the bacteria. It reduces the number of the bacteria, whereas a bacteriostatic agent only suppresses or prevents the increase in number. Whereas cidal agent reduces the number, it causes killing of the bacteria. Therefore, if the host defense mechanism is impaired, as in HIV patient, a bactericidal agent is preferred. The next factor is pregnancy. Majority of the antimicrobial agents should be avoided in pregnancy because they can cross the placental barrier and can cause teratogenicity or fetal malformation. The antibiotics that are safe in pregnancy are penicillin, many of the cephalosporins, and erythromycin. So these are some of the antibiotics that can be safely used in pregnancy, whereas majority of the antibiotics should be avoided or should be used with caution. Next is genetic factors, and a common example is glucose 6-phosphate dehydrogenase deficient patients, because glucose 6-phosphate dehydrogenase enzyme is responsible for maintaining the red cell membrane integrity. Because the glucose 6-phosphate dehydrogenase enzyme is responsible for NADPH formation, and NADPH formation is responsible for the formation of glutathione, which has antioxidant property. So because of the presence of NADPH, oxidative stress is reduced and the integrity of the RBC membrane is maintained. Therefore, patients who are deficient in glucose 6-phosphate dehydrogenase enzyme, they are more risk for hemolysis due to drugs with primaquine, nitrofurantoin, sulfonamides, chloramphenicol and fluoroquinolone. So these are some of the drugs that can increase the risk of hemolysis in glucose 6-phosphate dehydrogenase deficient patients. So we have discussed the pathogen related factors and also the patient related factors such as age, the end organ dysfunction, that is liver disease, kidney disease, local factors such as abscess formation, foreign bodies, presence of penetration barriers, host defense mechanism, that is normal host defense mechanism and impaired host defense mechanism, pregnancy and genetic factors. So these comprise the patient factors that have to be considered while choosing an antimicrobial agent. Lastly, the drug-related factors have to be considered before prescribing an antimicrobial agent. So what are the drug-related factors that are considered? So now coming to the drug-related factors. So the first factor is the spectrum of activity, which includes a narrow spectrum and a broad spectrum antibiotic. So a narrow spectrum antibiotic is used for definitive therapy and a broad spectrum antibiotic is used for empirical therapy. So a narrow spectrum antibiotic is preferred over broad spectrum antibiotic because it is less likely to disturb the gut microflora that is beneficial for the body, and therefore narrow spectrum is preferred over broad spectrum antibiotic. So the next factor is pharmacokinetic and pharmacodynamic profile of the drug. So this is a figure which shows the concentration plotted against time. Now certain antibiotics show concentration dependent killing, which means that these antibiotics are used in high concentration higher than the minimum inhibitory concentration. So So we can see that the minimum inhibitory concentration is shown by the red line, and the concentration that is used is much higher than the minimum inhibitory concentration. So the efficacy can be enhanced by increasing the concentration. Now this is seen particularly in aminoglycosides, which maximizes the concentration. So the entire daily dose of gentamicin is given as a single dose rather than in divided doses, because a single dose increases the concentration of the antibiotic above the minimum inhibitory concentration, and this produces better effect. Now what is minimum inhibitory concentration? It is the concentration, or it's a minimum concentration which causes inhibition of the bacteria. Also, there are certain antibiotics such as amoxicillin that produces time-dependent killing. So, for such antibiotics, the concentration is maintained at the minimum inhibitory concentration. So, they are used in divided doses for a longer period of time rather than using in high concentration. So, these drugs are given more frequently in divided doses. An example is amoxicillin. So the next pharmacokinetic feature is the penetration property of the antibiotic. So the antibiotic must reach the target site, must reach the site of infection in sufficient concentration for an adequate length of time. For example, fluoroquinolones have very high tissue penetration property. They can accumulate in high concentration in tissues such as soft tissue, bones, and prostate gland. Therefore, fluoroquinolone is the drug of choice for soft tissue infection, prostatitis, osteomyelitis, because of its high tissue penetration property. The second antibiotic is rifampicin, which accumulates in high concentration in intracellular levels. So it kills the intracellular mycobacteria. It kills the dormant bacteria that is responsible for relapse of tuberculosis. So rifampicin helps to prevent relapse because it acts on the intracellular bacteria. It kills the dormant bacteria and prevents relapse. The third example is ceftriaxone and chloramphenicol. They have the property to cross the blood-brain barrier and enter into the CSF. Therefore, they can be used for the treatment of meningitis, encephalitis. So the next factor is route of administration. In less severe infection, an oral antibiotic is reliable, but in more serious infection, a parenteral antibiotic is preferred. So the next is, while choosing an antimicrobial agent, relative toxicity is also taken into consideration. Obviously, a less toxic drug is preferred over a more toxic drug. For example, beta-lactams are preferred over aminoglycosides. And the second example is erythromycin, that is preferred over clindamycin. So erythromycin is preferred over clindamycin. So the next factor is the cost. Obviously, a less expensive drug is preferred over more expensive drug, provided they are equally effective and safe. So these were some of the drug related factors while choosing an antimicrobial agent. The pathogen, the patient factors, and the drug related factors are taken into consideration for rational prescribing. So what is rational prescribing? The right patient receives the right drug at the right dose, in the right formulation, at the right time, for the right duration of action, and also for the right pathogen and the site of infection. So right patient, right dose, right route, right pathogen, right site of infection, all of these are taken into consideration for rational prescribing. So thank you so much for watching. Please like, share and subscribe if you find this video useful.